I'm acutely aware that many in the audience are not basically working on HIV, maybe on hepatitis or the new other antivirals, but what I hope is that even among the HIV clinicians here that who are working in adults, we can see the challenges as well as the situation which we are still in for the pediatric antiretroviral epidemic. And then even if you're not in that field, you could then try to translate and see the challenges, whatever field, in whatever treatment that are associated with pediatric treatment. So next slide. So I just wanted to give a few slides on the pediatric HIV epidemic as we stand, because many people now, especially in the developed countries, may be thinking that this is nearly something of the past. But there's still 1.8 million children living with HIV, which is around 5% of those which are infected, out of 36 million globally. That means that 150,000 children newly infected last year, which is around 7% of the total that were new infections, obviously most in the adults. But still, when you look at the raw numbers, there's still 400 children infected every day. 110,000 children died of age-related illness, and that's translated to about 290. And when you look, this is probably related that still children lag behind the adults in getting children on treatment. So with only 49% of children living with HIV who actually have access to treatment. So again, with the 1990 targets, these bold targets, and what it's hoped that by where we are here, about 150,000 of new infections a year, by 2020, we can get down to about 500,000 per year. And obviously, 500,000 per year is still too high. We want to have zero per year. So here's just a graph of just looking at the trends which we see, and this is encouraging when you look at the green line, which is the pediatric HIV infections in, let's say, children 0 to 14, and you can see this steep decline. And hopefully, like you say, around about 150,000, and this trend should continue to go down, hopefully, and try to reach the goals of the 2020. But when you look at the adolescents, that these are not perinatally infected, these numbers of new infections are basically quite stable, not really decreasing that much. So this is the adolescent population might be a very specific population to focus on for interventions that maybe have been not neglected, but maybe not as focused on as much than getting this line down. We need to start to get this line down as well. And I will take a little bit of a speaker bias here, because I'm going to just say that in Thailand there's been great strides with my adopted country where I've lived for the last 16 years. They have done an excellent job with PMTCT, and they were the first country that announced last year in June to eliminate pediatric HIV, and syphilis, but that doesn't mean it's eliminated and gone, actually. It just means that there's less than a 2% transmission rate. Still, it's still pretty good. I think the transmission rate was about 1.95 or something like this, but it's still calculated as less, the elimination is there. So hopefully they can continue to drive this down, but clearly there's circumstances where women come late, they're non-adherent, so unfortunately there are still infections. So let's get on to the pediatric patient population. So I just wanted to say a very simple slide right at the beginning. So they have the IH guidelines and the FDA guidelines. So what are children? And I'm sure most of you know what they are, but just to tell you what they are. So a term children is 0 to 27 days, but obviously in the FDA they like to do something different, so they use months, birth to 1 month. Infants, basically 1 month to 2, children 2 to 11, 2 to 12, and basically that. So basically, I agree, this is not the most exciting thing I've ever said to people, but wait for the next slide. So really try to remember these boundaries. That's what I'm trying to get at. So what I try to do is when you think about these are those exciting boundaries I just said. Here you have the adolescents, children, infants, and neonates. So here, if we look at the drugs, what ages are they approved for? So if you look at Abacavir, it goes down to 3 months. DDI, it's obviously not used so much now, went down to 2 weeks. FTC, one of the few, I must highlight, goes down to birth, and the others, going around to these different regions. So with the NNRTIs, you can see, actually, most of them are not really linked to the actual age barriers, but they linked more likely to formulation and drugs available. But it's not too bad when you see this picture. Now let's look at the NRTIs. How is the picture different? Efaviren's pretty good, etravirine down to 6. Nevirapine, obviously been used a lot for PMTCT, which is not approved for PMTCT, actually. It's only approved really for treatment in the label, but it's obviously used for breastfeeding, prevention, etc., transmission. But you see Riplivirine down to 2, but there are some studies, the IMPACT study 1090, going down to etravirine lower, so there are some impacts. But when you see again, when the NNRTI choice is pretty limited when you come down to it. PIs, similar story. I'll go a bit faster but I think you're getting the idea now that I want to show that really that these, what we say, like these cutoffs, so for the adolescents, they are for different drugs, really quite variable of what you can get down to. So the choices available are pretty limited. And then finally, the integrase, raltegravir is probably the best now, down to 4 weeks. Dalraltegravir getting down lower and lower, but elvaltegravir, I guess in Stribel it's down to 18, but then when you get the newer fixed dose down to 12. So there are efforts to get it lower, and then the other fusion inhibitors, et cetera, down to 2. So again, there's ongoing studies, which I don't want to forget, that there's several impact studies which are now trying to move these further and further to the left to get these available for children. So we're not in bad shape, but when you look at the DHSS guidelines, and this is very, in the US, you say, oh, this is excellent for adults. You mean, over the years, this is basically translated into now really once a day, they're never safe, but safer drugs with TAF, dalraltegravir, Triumec, these really excellent drugs which are now really helping patients. But then you look, even the preferred ones are, TAF, efavirenz, rilpivirine, darunavir. So then when you look at that, you think, oh, the things aren't so bad. But when you look at the children guidelines, and let's say you want to treat them before 1 year, it's a completely different picture. You start saying things like lopinavir, where I say to some in the audience, like Marta, she's probably not used lopinavir for 10 years, but it's pretty much used. It's the first-line treatment for children. And even nevirapine, which I think if you were new to the thing, you'd probably never heard of this drug if you're in adults. But it's still used in children. So this is why I wanted just to have this real contrast between the adults and the children and what's available in terms of the treatment. But it's not all bad news. And as Bob touched on that, basically there's been a huge amount of effort by people like Bob trying to really push through new laws by the FDA and the EMA to try to force, well, maybe force is a bit strong, encourage drug companies to do pediatric studies when they try to ask for approval. So there's been these separate acts of law passed through Congress to try to stimulate them to do this. Same in EMA. Now I'm sure you have the PIPs, or the Pediatric Investigation Plans, which they have to submit to as part of their approval package. Now, this was just taken at random, so anyone from the company, I'm not fixing out tenofovir particularly. I just wanted to show that this was first approved in 2001. So then it didn't get the first down to 12 years until around 2010. So 9 years to get that done, but this was with the encouragement to get put down. Then you go down to didn't get down to about 2 years till 2012, and then basically under 2 years, I'm not sure of the situation, but they probably still have some discussion on what to do with this age group, but maybe now with the newer formulations, it might be different. So you just wanted to give an example, and again, it's not a criticism, I just wanted to show an example of the timeline of what really happens when you get from one drug to get it into the pediatric age group. And at the same time as the branded drugs, the WHO has been really heavily involved in trying to develop formulations or encourage companies to produce solid formulations, particularly for those less than 14 kilograms, so about 4 to 5 years of age. And they actually started the Pediatric ARV Working Group, or PAWG. It was formed in 2006, and their main objective or goal was to try to optimize really the dosing, try to produce, instead of milligram per kilogram dosing, they tried to really use weight bands, try to simplify it, to try to reduce the number of errors which could occur with different dosings, especially when you have in resource-limited settings where there's a high turnover of patients. And at the moment, I'm the co-chair with Elaine Abrahams and Victor, where we try to come up with simplified weight dosing and advice for new formulations. And this is what you would see if you look in the WHO guidelines. Completely different to the DHSS or the BIVA guidelines, where they start to have these weight band dosing. They have nice colors. You can see that you have these 1, 2, 3, 4, 5, 6 weight bands. So again, with these different formulations. So it's very different to have this weight band dosing. And obviously, when you have weight band dosing, you can perhaps overdose, hopefully not too much, or underdose when you get to the end or each side of the weight band. So that's what a lot of the work is to do, to see if you give, at this time period, if you're 5.9 kilograms, you have 1 tablet, how are you getting close to being underdosed or not? And this is obviously the limitation of weight band dosing. And there was a meeting recently in Geneva where it's all these acronyms, sorry, PAWG talked to the PADO, which is the Pediatric ARV Optimization meeting. And they have this meeting every 2 years. And it was in Geneva in December. And now they've come up with these lists. And these lists are sort of given out to generic companies and other companies, and advice say these are what we believe in the next 5 years or so into the future, what would be the best regimens for you to produce for pediatric. So you see you have a Triumec for children, maybe the TAF FDC, or a darunavir, a small tablet like a fixed dose tablet, but lower to what's not available. And obviously, these aren't always produced by the generic, the branded, the original company. So the generic companies may take these on if allowed. So, but what happens when you want to do the study? We're quite lucky in terms for HIV that the extrapolation from the PK for the FDA is probably enough because the disease progression is quite similar. So in terms of the regulatory approval process, that can be quite relatively straightforward. So for HIV, in that respect, a lot of the time PK data as well as some safety are almost sufficient, while obviously in other diseases you need to have, where the disease in children does not match that of adults, you have to be more careful in terms of the PK/PD approach, and this would require more data for the regulatory agents. So I just wanted to give an example of what, you see, when you design a pediatric study, some of the challenges and probably some of the slow. So this is the IMPACT 1093 study. It's ongoing. It's looking at the PK of dolutegravir in children. We're one of the study sites in Thailand. And basically, there's this step-down approach to cohort. So you have basically these 5 cohorts going down by age group. So you enroll the first one. If you pass the PK, you go to the next one. And then maybe you then submit that to the FDA. Then you continue down, down, down. So this is a nice conservative way to get the right dose, make sure you're not overdosing, going down slowly, slowly, slowly. But obviously the inherent problem with this is that it can lead to a delay in the drug availability. You have to go slow here, wait 6 months. So actually this study probably started in 1990, 2000 and seems like that, 2010 or something like that, and they're just now opening these weight bands, so it's taken about 3 or 4 years to get this done. So it's a long process. So we have to now think what could be the innovative strategies to try to somehow optimize maybe the dose selection so that we could maybe enroll consecutively or concurrently, these weight bands. And this is what I have one slide on this, but I think Dr. Ward's really done this justice in the last presentations, because the developmental pharmacokinetics is so complicated between, say, 1 day of life and 6 years up to maybe 15 years old, that these differences in the absorption metabolism, the maturation, the change in the excretion really make predicting the dose, what you need, quite complicated. So if you have to do it today, one of the most common situations, basically the pediatric dose is just normally involves scaling for size. So basically just going down from an adult, either based on a milligram per kilogram dose or on body surface area. So this is not that complicated, but it can obviously lead to inherent problems. And even just doing this, using a milligram per kilogram dose, even in a developed setting, leads to underdosing due to miscalculations, etc. So this isn't one advantage of the weight band, but this kind of direct extrapolation down or linear extrapolation down in some aspects is not very accurate, because we know that drug elimination is non-linear. Basically, it's non-linear when you talk about size. So going down linearly is not accurate. So what can we do? One option is to do this weight-based allometric scaling. So this is where we use, to predict the clearance, this 0.75 to the power to try to increase the accuracy of predicting the dose. And this is a graph of the clearance versus weight. And if you have the blue line, basically this is the linear milligram per kilogram dosing. But when you use allometric scaling, basically the dose per kilogram is higher in children, so down here. The dose per kilogram is higher, so which we know that the younger children are going to need a higher dose, but when you use this kind of dosing, perhaps in that younger age group, you're allowed to give this higher per milligram dose per kilogram to make it maybe more appropriate. But that's not the end of the story. It's not just allometric that can solve all problems. Obviously, as Bob said, we need to have drug regimens not really the same for neonates and children. This is because of immunophysiology. So how can we describe this? Because mathematics can basically solve everything to some extent. So we pretend that the postmenstrual age is this beautiful function, this Emax function. And we're using postmenstrual age, not postnatal age, because in the fetus, obviously, they are developing their excretion and pathways. So we have to take that into account. On day one, it's not suddenly, I have metabolism. They've already got some metabolism maturity already. So then they can use this kind of curve so basically when you get to the flat up here, it means that they have the adult clearance. So it takes time to get up to the adult clearance in terms of maturation. And if you look at drugs by CYP3A4, the glucuronidated drugs, you see that the time of maturation, depending on the pathway, is different. So you can see that, again, including the maturation may improve the prediction for dosing. So if you have this nice, I wouldn't say a simple equation. If you want to estimate the clearance in a child, you could have the adult clearance adjusted for size, like weight or BMI. It's just something to really to explain the size aspect, or maturation, but basically down to 2 years. So there is some argument that people might say that actually children more than 2 are small adults, while neonates are immature children. So it's a slight twist on the classic children are not small adults, but maybe they are if they're above 2 years. But in terms of neonates, really, if you take the maturation and weight, it might be a better idea than just the linear scaling alone. So when someone's looked at this, they took the prediction of clearance in children. They looked at here's the size, here's the maturation. And when they took all of these drugs, and it's not just antiretroviral drugs, there's antifungals, antibiotics, et cetera, and pain medications. And if I put on those boundaries, like I say, the thresholds for 6 years old, the blue line being just weight predicted, while the red line being weight and age, so including maturation, you see, I hope you can see anyway, I cannot see from here, but they basically go down to about this line. Here, again, down to 2 years, remember that you'd think that the maturation is better. So the blue line is starting to shift. If you go down to 6 months, the weight alone is not that good. But if you go down with the maturation as well, it's not too bad down to 6 months. And after that, it's not that great. So it's not perfect by any stretch of the imagination, but I think including the size and the maturation, at least down to 1 to 2 years old, maybe a more appropriate way to predict the clearance and maybe have a more accurate starting dose. And then finally on this issue, I probably couldn't get away with not mentioning PBPK, or the people from Liverpool start heckling me, where's Marco? So we need to do, but this is exciting because actually the FDA, and maybe they can comment, is that the PBK modeling now is being encouraged, let's say, for pediatric drug development. And this can really complement the allometry, which we know already. So there are some examples, I won't go into the details, of how workflow to do a PKP model from adult data down to children. And then you can do these models for different wage groups. Although if you look, this one does not look great, by the way. So again, you see that even with PBPK, it's not magic bullet. You cannot do everything, even in the neonates. But I think it's an important tool that could be utilized to complement the allometry idea. And other options are available as well as doing modeling. I think one of the interesting things, at least in HIV, is that we have the opportunity for prophylaxis dosing and then treatment. So moving from prophylaxis, can we then predict the treatment dose? And there's an extra bonus if you can tell me afterwards which bridge this is. I'll give you an extra point. So washout PK. So this is a little bit of a good opportunity. So this woman is, let's say, HIV infected. She's on a raltegravir-based regimen. So we know raltegravir can cross the placenta. So when this child is born, even though it's never taken raltegravir, it has raltegravir in the blood. And then we can look, okay, what is the washout of this raltegravir in the baby, get some idea for the clearance and things like this, and then we can then start to maybe use that information to predict the dose for infants. And that's what they've done in the IMPACT 1110 study. Again, I'm not going to go into the details, but I want to really highlight that even from 1 week to 6 weeks of age, there's a 8-fold difference in the dose. So you're going from once a day, 1.5 for the first week, up to 6 milligrams twice a day within 6 weeks. So that is not a simple dosing, and the WHO weight band dosing is probably not going to like that kind of change. But I think this is a complicated change, but it's been shown that actually by doing this, which is probably not a simple thing to do, it does give good doses. So even though you have this nice, again, implementing this on a public health scale in resource-limited settings may be challenging, but it shows that even if you know the dose, it might be hard to do practically as well. And finally, I just wanted to touch on the formulation. So I've talked about getting the right dose and see if we can get more starting. But even if you have the right dose, you need to have the formulation as well. And these are which you probably don't see, all of these liquid formulations, which are not that exciting. But I want to just highlight an example for lopinavir. So in 2000, we got the soft gel capsule in addition to the liquid, the Calitra liquid. 5 years later, they switched to the adult, so we're taking away the soft gel capsules to these Meltrex adult formulations. 2 years later, they did a Meltrex Pediatric. But there's still nothing really for, if you can't swallow the tablet, and you can't crush this tablet, it's like a stone, I think. So you can't really do it. So you're still limited to the oral formulation. But as Bob said, there's these toxic polyglycol and these alcohol, which is in this, is not that good for newborns. It's actually contraindicated for children more than 42 weeks or 14 days of age. So basically, what they've come up with in the last few years is this. It's got 100 different names, or mini tabs, pellets, but basically it's this tablet made into small cubes. And then you open it up and you sprinkle it on food, and then they can and take it in that way. So this was an innovation, let's say, to try to get away from the liquid and to move away from the tablet. And it has worked quite well. There has a study in Uganda where they compared the mini tabs or pellets versus the liquid, and actually the mini tabs was better than the liquid in terms of exposure. When you compared to the tablet in the older kids, the tablets, the actual Meltrex tablets were better than the mini tabs. So it's not a perfect formulation because it's still not very nice to taste. They haven't got rid of the taste. So it's just because of the tablet, it's just a mini tab, the taste is still not very acceptable. So the next idea was to try to make this, it's not approved yet, but that's the idea, this 4-in-1 FDC taste mask granule of lopinavir, and try to merge that. And this is a project with DNDi and CIPLA, where they're trying to put lopinavir, ritonavir, 3-TC, abacavir into one powder. It can, again, just be open, 4 drugs in one capsule. It's taste masks, no cold chain, and it can be used. And this, hopefully, if they can get this powder together, they should start a phase 1 PK study in Uganda. And when you talk about this with people in the HIV community, they say, well, you're still using lopinavir and doing this, but I think there's not that much choice, actually. I mean, obviously, everyone would love to get a nice dolutegravir or a formulation or one of the rilpivirine or something like this for the young kids, but this is where we are, unfortunately. I think this will still, if it comes out in the next 6 months to a year, I think it will still play a role in certain settings. Maybe then once the dolutegravir comes through, the formulations are available, the dosing's available, and maybe some generic form, it may switch. But at this time, this is still where many people are going. And at the same time, I put a slide here from Andrew Owen from Liverpool, who presented at the CROI. Maybe some of you have seen it, where they're trying to also, in addition to maybe these pellets or granule formulations, trying to use nanoparticles to try to develop a more appropriate lopinavir and even efavirenz formulation. So this technology can really be maybe adapted for any of the antiretrovirals, and more of a proof of concept that you can use nanotechnology to improve in this case for lopinavir, the solubility and reduce the dose. One slide again, just on again, you know, you've had abacavir 3-TC efavirenz for adults for a long time, but there's not one for children. So they've been trying to design this formulation for children, again, with the WHO trying to make these weight band doses. They finally come up with this nice analysis we did with pooling data from several settings to look at get the weight band formulation for this formulation. This is the ratio here. And hopefully they've started to make it, I know, in some of the companies, but it's still yet not available. So again, you can have these nice ideas, these nice weight band formulations, but it's either you have the formulation or not the dose, or the dose and not the formulation. So to get this all to come together can be a little bit challenging. So here's the issues with the FDC. So we maybe in the future have this abacavir 3-TC efavirenz, which goes down to 10. Maybe we'd have the 4-in-1, which is planned to go down to 4 kilograms. But again, they're not available. It looks nice on the picture, but it's not reality. You have the other excellent new FDCs for adults, but how are we going to get these formulations down to children? There's several factors. You need to have the different ratios going down, 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 which is not simple. And having these in a nice formulation for children is the challenge. So even breaking through these barriers to get from 12 to 2 to thing is not a simple thing. And you can see that even the ones we've had for many years are not really optimal yet. So in summary, really, optimizing the drug dosing for pediatric populations in general, it really depends on the developmental pharmacokinetics. Using the standard approach of dividing the dose is really based on the milligram per kilogram is not optimal. Perhaps using maturation models or allometric scaling or in combination with PBPK might be a better approach. At least for HIV, I mean, like I say, we have these washout studies where we can take the prophylaxis data or that in breastfeeding infants, for example, and try to extrapolate to get dosages for treatment. Development of the formulations is a major hurdle. I mean, that's the most obvious thing I will say today. More FTCs for children on the horizon. Let's say long-acting. I know there's these excellent long-actings coming through for prevention and treatment. Adolescents need prevention as well. But getting these into a dose for children and getting into the lower age group maybe for prevention is a huge undertaking, and I'm sure we'll be equally behind the adults in that respect. And I put this one on the end, but it's not really specific for pediatrics, but I think we still need novel monitoring tools, even for children who get the treatment, get the formulation. We need to have some support or some sort of nice monitoring tool for medication adherence, because these children are going to be, if they're starting at 1 year of life, hopefully going to be on treatment for the next 50, 60 years, and that's a long time to take some treatment without the long acting, let's say. And this is where we really need to have some tools to help them through different periods of their life where they need to have close medication adherence. And with that, I'd just like to thank all of the institutions and the people that are involved in these kind of activities with the Pediatric Antiretroviral Program. So thank you very much.